Good morning and welcome to today's presentation. How many of you have taken Comet K 2010? Considering that not more than 5% would have taken it, on that assumption we have conducted the same paper because it's a true university exam paper. There is no examiner bias creeping into it. When we conduct a mock test, sometimes we create unnecessary questions. We create relatively tough questions which are never asked. So to remove the examiner bias, let us have some real examination papers. That is the whole idea. So let us make the start. For thyrotoxicosis in the pregnancy, what is the safest drug, doctor? You all agree with me that it's a propyl thiourazole. Around 50% of the questions are all from the old question bank. Even a super duper examiner has no other choice to pick up 50% from the old paper. A 40-year-old male has got severe abdominal pain and radiation to the back after receiving a blunt abdominal trauma, and there is a minimal retroperitoneal hematoma. That itself speaks. What was the structure that we all have worked on when we were doing a retroperitoneal dissection in anatomy days, doctor? So if you look at abdomen, there is an intrathoracic abdomen, pelvic abdomen, retroperitoneal abdomen and the true abdomen. That is how the abdomen had been divided into. The retroperitoneal abdomen contains kidneys, ureter, pancreas, aorta and vena cava. And the very fact that the pain is radiating towards the back with the presence of a retroperitoneal hematoma highly suggests that it is a pancreatic injury is what need to be remembered. Just like in the case of the acute pancreatitis, there is a periumbilical hemorrhage, Cullen sign, and Turner's sign with a flank hemorrhage. Even the similar things can appear even with a retroperitoneal hematoma formed by the pancreatic injury in the blunt abdominal trauma is what need to be remembered. Now Sigmund Freud's Oedipus complex, what is the meaning of it? It's quite obvious that the boys admire the quality of their mothers, the opposite sex, and try to identify the final sexual partner relationship who has more or less similarity to the features of the mother. So also the boys, if your father-in-law is a surgeon, if you don't do MS general surgery, it is there is little chance to get a chance to tie a ring of the girl whose father is a surgeon. So that is exactly is all about Oedipus complex. Oedipus and Sphinx were the great part of the Greek mythology, where there is a large unconscious ideas and feelings which center around the desire to possess the parent of the opposite sex and eliminate the parent of the same sex. That starts from the age 2 to 3, and by about 8 to 9 there is a resolution of that. That is, they will overcome that. Suppose if they don't overcome that, then the problems like homosexuality, lesbianism, etc. basically creep into the individual's personal sexual life. So it is the successful resolution of the Oedipus complex which is very important and desirable developmentally is what need to be basically remembered. So the answer would be that the child loves and longs for the parent of the opposite sex is all about the Oedipus complex. Then sarcoidosis can mimic the chronic beryllium poisoning. It will also lead to similar radiological features similar to that of the beryllium poisoning is what need to be remembered. Now this is a very good question, doctor. There is a very high chance that our forthcoming state entrance also we can have a question similar to this. The cochlear nuclei belong to which type of embryological evolution? So how are embryologically the various cranial nerve nuclei have been divided into? Special somatic afferents, special visceral afferents, general somatic afferent and efferents, general visceral efferent and afferents, and accordingly the various cranial nerves have been divided depending upon whether they have a pure sensory part, whether they have a pure motor part. Is that motor is serving special senses or visceral, so or somatic, accordingly it has been divided. I leave this to this table is there with you, I believe, and it is there in any entrance book, basically not a big deal. So, but the point of interest here is we should somehow make a method to quickly revise this kind of the things which we can't get rid of. That's a whole bad part of the entrance exam. Suddenly one accessory now can be picked up and you may be asked, does it have SSA, SSV, I mean GSE, or what kind of component does it have? This last 1 month consolidation of preparation is all about some sort of a way to recall all these common muggable aspects also. Now how does ethanol, this is a pure logical question, will make your bladder full? When you have a full beer, you feel like going to toilet more frequently from the bar. What is the reason for that? So ethanol inhibits the vasopressin secretion. Vasopressin is antidiuretic hormone. If there is no antidiuretic hormone, then there is diuresis. That's how the ethanol induced diuresis basically happen. Then I leave to you, is this table given in your literature? I hope so. So the various diuretics, which part of the nephron do they act? What are the common side effects? Please remember, the top 500 topics, diuretics is definitely one which is going to appear in exam. The primary sinusoidal dilatation, what is it basically called as? So before that I like to ask you, what is hyperlobatum? Hyperlobatum is a syphilitic cirrhosis where in syphilis the liver will get a nodular lobulated appearance which is called as the hyperlobatum. Then what is von Meyenberg complex? It is the bile duct hematomas which will be forming, which are called von Meyenberg complex. Now this is a typical 65-year-old man with primary biliary cirrhosis with pileosis hepatis, where you can see the homogeneously enhancing lesions which are spread across the liver, you can see, which is classical of pileosis hepatis. So it is the pileosis hepatis which is the sinusoidal dilatation of the various venous sinusoids in the liver is called the pileosis hepatis. So if you take the histopathology, we find a large blood cysts which are scattered throughout, sometimes lung, sometimes liver. It is not only limited only to the liver, is what need to be appreciated. Then once more there is a parenchymal type, etc., etc. When you do MD pathology we will read all that. Now the physical quality of life index, it does not take into consideration the income, because a poor man can be happy, a rich man can be miserable. So that's the reason income is not included, but infant mortality, literacy, life expectancy at age 1, they are all included under the physical quality of life index. This is a relatively practical question. In ARDS, what is the tidal volume that should be set? Forget about ARDS. I like to ask you, non-ARDS patient, if you put him on ventilator, what will be the tidal volume settings? First, before we go to this question, I like to ask you, how many of us are exposed to a ventilator patient care management in MBBS? Are we? No hands rising, right? But we will be asked, ARDS, how much do we set? Of course, in MD we all manage ventilator, that's not a big deal. But at least theoretically you should know. So now let us talk about it. A tidal volume of 6 ml per kg. Let us say I am a 50 kg individual or a 70 kg is the average weight. You will set it at around 420 ml is what you will generally set the ventilator tidal volume setting if it is a case of ARDS. Actually in ARDS the lungs are more stiffer. So we tend to achieve a lesser tidal volume rather than a higher tidal volume. So a non-ARDS patient who doesn't have any pulmonary edema, in such an individual we will normally put tidal volume at 8 to 10 ml per kg on the ventilator settings is what we all need to basically remember. But just because of this question, one should not go to Harrison and read the whole ventilator chapter. There is no use. Even if we read, we forget it. Let me tell you. we tend to forget it unless you are practicing it. Now persistent priapism is rarely seen in. I had a difficulty in finalizing the answer as sickle cell disease because leukemia also is known to lead to spinal cord metastasis or damage, also is known to lead to priapism. Maybe we need to give the Renan-Martin English grammar of rarely seen. So rarely seen, does it mean definitely seen, but not commonly seen? Maybe that is the reason. But sickle cell is the most common cause of the priapism in the case of pediatric population. And what is the most common cause of the priapism in adult population? The anti-impotence drugs which are being taken are the most common cause of the priapism in the case of the adults, and many other drugs which increases the vascular engorgement of the corpus cavernosum. They're all the ones which are responsible. Now once more, in priapism we have a low flow, high flow priapism. It's all a big discussion, priapism. Then but anyway, for entrance we can remember all the drugs for erectile dysfunction management are the most common cause in adults, and sickle cell disease in the case of the children. And internationally the most common cause is idiopathic, because we have more idiots worldwide. So that is the underlying reason. Now for the colonic polyps, what is the best way that you can be able to detect out of all tests which is having very high sensitivity specificity, is my question to all of you. Now we are in a modern imageology days, CT MRI. So what is the modern buzzword for the colonic polyps, doctor? If we use CT or MRI technique, it's called computed colonography, which is non-invasive way of delineating and imaging the colon. It can be able to detect all the polyps, even small size, 5 to 10 millimeter size also. Do you know what is the most common cause? What is the most common cause worldwide? Gastroenterologists fall into a medico-legal complication. Why they are being sued in London, Paris and all the countries? If you are a gastroenterologist and already had done colonoscopy and missed a polyp, that is one of the most common medico-legal pitfalls across worldwide among the gastroenterologists. So you should naturally know their only job is put a endoscope, put a colonoscope. If you still have a little itchy hands, do an ERCP. The average day of a gastroenterologist is busy into these three main procedures. Just like a driver's job is only cleaning the car and then parking the car and driving the car, that's all. Or ma'am saab puche to jara garden ko watering karna, that's all. So also is the situation when you become super specialist. So now let us talk about it. We have sigmoidoscopy, stool heme test, double contrast barium enema. What do you mean by double contrast? What is one contrast? Barium, other is air. So double contrast barium enema. Out of all, it is the double contrast barium enema study which is the principal radiographic method for assessing the colonic polyps, is what need to be basically remembered. So this is how, if you do a double contrast barium, you can see the presence of a hematomatous polyp in this case, histologically. Don't say it is a hematomatous polyp radiologically. You will be sued by your own resident. So it's histologically, but you can see the presence of a polyp when air and barium had been thrown. What is the special advantage of barium, doctor, compared to that of the CT or MRI? Barium can be able to make you detect the mucosal defects of the gut, which may be missed definitely by CT or MRI, is what need to be remembered. Student's elbow is olecranon bursitis. Oh, this is a little naughty, tricky question. How many of you answered it as the head of the fibula? Please help me to raise the hands. No, very good. Only one or two, I am happy. I mean, the first tendency is the same, because we all know that fibula has a head. If there is a head, there will be a neck. If there are neck, there are shoulders. That's how the human imagination continues into. Because if there is a god, he will have an arrow. If he has an arrow, he knows he is an archer. If he is an archer, he is the best archer. So if you look at the common peroneal nerve, it is in a very close relationship with the neck of the fibula, where subcutaneously it is palpable. Against the neck of the fibula is what need to be basically appreciated. So these are all the ouch kind of mistakes that we do in the exam hall. Then glycoprotein 2B3A receptors. Can you tell me a drug which is against them, doctor? Apiximab is the one which is against the glycoprotein 2B3A receptors. Very traditional paper. One question should definitely be there on antiplatelets, aspirin, clopidogrel, etc. You should be very sure. Now let's go to the next question. A 22-year-old software engineer shock DIC multi-system failure and modified Thayer-Martin medium had been used. So now let us talk a little bit microbiology, but before that, anyone to say Fitz-Hugh-Curtis syndrome as a tendency? At least even if one or two is there, please raise the hand. Otherwise, we don't lead the discussion there. Good, because that is also gonococcal, perihepatitis in gonococcal. But anyway, there is a chocolate medium where there is an overgrowth of all the rectal or urethral sample specimen. If you grow, all organisms will grow. It is not selective. But Thayer-Martin, only the Neisseria will only grow. So Thayer-Martin, it has grown means it should be Neisseria. So considering the presence of DIC, multi-system failure, shock, etc., we conclude that it is Waterhouse-Friderichsen syndrome, which is caused by the Neisseria, is what need to be remembered. Now, which is not a cause of the right axis deviation of ECG is a very important question. How to recognize right axis deviation, doctor? Lead 1 and 3 you should look at. The lead 1 is down pointing, lead 3 is pointing up, positive, lead 1 is negative. So both of them are looking towards, right towards each other. But lead 1 is positive, lead 3 is negative, they left each other. So a simple way looking at the ECG, you can decide right or left axis deviation. So what are the common causes of right axis deviation? Normal variation, COPD, right ventricular hypertrophy, right bundle branch block, left posterior hemiblock, dextrocardia, left ventricular ectopic rhythm, and WPW. So anything that delays the conduction towards through the right block, right branch of the bundle of his is the one which is responsible. Now even with deep inspiration, there can be right axis deviation. A tall, lanky individual, 6.2 or 6.3 Marfans, if you look at ECG, you may identify right axis deviation, which is otherwise normal. So it is in the standing but not in lying down where we see the normal right axis deviation is what you have to basically understand. Now with regard to the various helminthic organisms, it is the ingestion of X everywhere. But it is not the ingestion of X, rather the penetration of the larvae percutaneously under the skin, which is responsible in which situation is the question. So if you look at Ascaris, it is the infective X. Trichuris trichura, which is whipworm, also is infective X. Pinworm, enterobius, they are deposited around perianal folds and that lead to perianal wriggling sensation where they will be mounting on the fingers of the wriggling individual and they are also basically ingested, infective eggs. Then Strongyloides turcuralis has got a heterogenic life cycle with a free living generation and a parasitic generation, and it has typically not by eating the eggs, rather it is by the infective larvae which go percutaneously in case of Strongyloides turcuralis. Now what is declaration of Oslo is an important question. In 1970 they have adopted the statement on therapeutic abortion. What are the guidelines for the therapeutic abortion is called as declaration of Oslo. What is the recent declaration of medical council? What is the news that you have read? Every district will have a national, what is it, Bachelor of Medicine, Bachelor of Surgery, no, Bachelor of Rural Health is a plan. 300 medical colleges are getting opened. Coaching gurus will have a lot of business. But at the same time, luckily, I mean, still your peers need another 5 years to come out. By the time they will also get some sort of a Supreme Court legislation for them to get eligibility for MD entrance. So you should be sure that we will have about 1,000 student classrooms also at a point of time. But anyway, that's required because in villages, when a post MBBS is not available, at least there must be somebody else who should be available. Now 25-year-old, but I was just asking one of my friends, a very brilliant guy, he took USMLE, went to US and some Sinna Kitty or some place was there, he is practicing. So another friend went to Harvard. I asked, how is that other guy in our days? He is the one who cracked USMLE. We are all useless fellows. If we take USMLE, we don't even cross 50 percentile also. What is he doing now? He is a rural consultant. So there is a Central America with Arizona with a desert in that like old Mexican movies. So there he will be practicing. So that's the reason maybe in India you have a privilege to practice in Mumbai and Hyderabad. So the question is all that our preparedness to go to villages, if that is not there, there must be an alternative system to support that. Now at 25-year-old, progressive loss of vision, 10 years of duration, crisscross lines on the cornea which are bifurcating, and amyloid deposition is there. This is what exactly I like to emphasize, doctor, that corneal dystrophy is a favorite topic of the examiner. You take recent All India exam, there was a question about most dangerous and the rarest form among the corneal dystrophies. Is it macular, is it lattice type, what kind was the question. One more exam there was, which is a superficial corneal dystrophy, which is a stromal corneal dystrophy. You must know the classification of corneal dystrophy. So it is in the lattice type of corneal dystrophy which is associated with the amyloid deposition is what you have to basically understand. In pregnancy, ACE inhibitors are not given, they are strictly contraindicated, very traditional question. Then what is diabetes control and complication trial? I like to ask you, which complications you call micro, which are macrovascular complications, doctor? Coronary artery disease, peripheral vascular disease, stroke, they are all called macrovascular. Whereas retinopathy, neuropathy, nephropathy, finally Tirupathy is basically called as microvascular complications of diabetes. Now as a diabetic consultant, you have two challenges. If you go for a strict glycemic control, what is the complication which can occur? Nocturnal hypoglycemia can be there, by morning the patient is dead. Strict, if you say 100, if you cross, I don't feed you. If you restrict the patient to that very bad level, there is a chance that if sugar cannot cross 100, no way, if you say that, he may end up in hypoglycemic episodes. But if you give a liberal sugar levels, then these complications can come. So DCCD trial basically said, by a strict glycemic control, what we can do is microvascular complications of type 1 diabetes can be better controlled than the macrovascular, but microvascular are definitely better controlled is what is being enunciated by that landmark trial which is called the diabetes control and complication trial. Vulvovaginitis can be due to estrogen deficiency, forgotten foreign body, or a worm infestation like pinworm infection in case of the pediatric population, but generally chlamydia is an organism you find in sexually active young female rather than the pediatric population. Now this another dirty question which you have to accept to remember, because cervical cancer, endometrial cancer, ovarian cancer, breast cancer, staging, you must be 200% sure, is it 1 centimeter, 5 centimeters, etc., etc. So now let us debate about it. Any tumor which is greater than 5 centimeters in diameter is called T3. This table is given to you, right? So I know that you all know how to read that table. So T3. Luckily there is only two options with T3. There are no metastasis, so it is M0. So option becomes T3. Even if you don't remember whether it is N1, N2 or N3, doesn't matter, it is T3, N3 and what is? T4. Why T4? Yes, doctor? It is 8 centimeter breast lump that is adherent to the skin, okay? Tumor of any size with direct extension, oh very good, very good. So we should revise, I did not see that. So but it doesn't fall into, then it should become T4, N3, M0, okay, option B should be the correct answer. Very good doctor. Now let's go to the next question. Nitrous oxide is typically a blue colored cylinder You should remember pin indices. Pin indices and the colors of the cylinders, which is the favorite question. So the nitrogen cylinders can have blue shoulder and oxygen cylinders have got a white shoulder. Previously black in United Kingdom, that's how they both vary. This is a good question. In MRI, what happens to the T1 and T2 relaxation times? First of all, doctor, what do you mean by T1 relaxation time? That's my question to all of you. Basically, it is the spinning of the protons in the MRI. So they can have a longitudinal relaxation time and they can have, on the other hand, a transverse relaxation time. So T2 is transverse relaxation time and T1 is called the longitudinal relaxation time. Now who decides T1? The T1 is the time which is required for a given substance to become magnetized after being exposed to a magnetic field is what need to be basically remembered. That's the reason any paramagnetic substance in the surrounding area definitely influences the T1 is the carry home message. Now you can see that whenever the CSF has two options. What are they? CSF can become localized only in the ventricles or it can percolate into periventricular white matter if there is an increased intracranial pressure, right? So when the CSF is forced into the periventricular white matter, whenever there is any interstitial edema because of any hydrocephalus or ventricular obstruction, then the T1 relaxation time typically becomes much shorter is what need to be basically remembered. Now if you take any subacute hemorrhage, whenever there is a hemorrhage it has got a hemosiderin inside it. Hemosiderin is a paramagnetic substance and such a paramagnetic substance will cause once more shortening of the T1 relaxation time is what need to be basically remembered. But at the same time we should realize that the same paramagnetic substance can also shorten the T2 relaxation time also, both T1 and also T2, but more significantly the T1 relaxation time than T2 is all the story about it. Then what is Brickwatt syndrome is my question to all of you. There will be multiple physical symptoms for which no physical evidence will be there. It's a personality disorder in which alcoholism and somatization disorder occur together. An alcoholic will start complaining of multiple somatic symptoms which do not have a physical basis is basically called as a Brickwatt syndrome is what need to be realized. All of you know that cavity formation is post-primary, whereas cavity is not a part of the primary. Tuberculosis is a very well known fact. It is a gamma globulin whose reduction is associated with the primary immune deficiency. 2, 7, 9, 10 are basically the vitamin K dependent factors is a very well known fact. Even protein C, protein S which are fundamentally anticoagulant, even there also vitamin K dependent factors is you should what remember. Now the benzodiazepines, especially lorazepam has no active metabolites. That's the reason you can safely give it in a patient who has got a liver dysfunction or a liver failure, where you can't dare to give other benzodiazepines like diazepam, etc. You can still give lorazepam is what need to be remembered. This is a good question. Hashimoto's thyroiditis. How many of you answered it as I don't think there will be alternate answer. Anybody thought it as thyroid stimulating antibody? Huh? You would like to say TSH? Receptor antibody? It's a good proposition. There are TSH receptor antibodies, but if you take the type of antibody predominantly present, responsible for tissue destruction, it is the antithyroid peroxidase. Second most common is antithyroglobulin, and the least most common would be TSH receptor blocking antibody. That is all the story about. Then rosette cataract is what you see with ocular trauma. It is the most common type of trauma induced cataract. We use tavudine, nelfinavir, zidovudine, lamivudine, but not acyclovir in the prophylaxis of the HIV, as all of you agree with me. It is the fundus of the stomach where stress induced ulcers, body and fundus, they are much more common compared to that of the anthem. And after you have given a beta 2 agonist, if at all there is a more than 15% increase of the FEV1 after 15 minutes inhalation of the beta 2 agonist, then it is called as a reversible airway obstruction is what need to be remembered. Trichomonal vaginitis, what is the treatment of choice, doctor? Metronidazole, it is not doxycycline because it is not chlamydia, is what you should be quite sure. Then it is the catecholamines and dopamine which are known to cause the inhibition of the motility of the stomach is what need to be remembered. Then what is glycopyrrolate? Glycopyrrolate is the muscarinic anticholinergic which doesn't have a central anticholinergic affects is what need to be remembered. Then what is the most common airborne contact dermatitis, doctor? Famous question. It is Parthenium hysteroforum. What is otherwise called as? Which party grass? Congress grass is what you should be very sure about, nothing to do with politics. Now COT test is basically for the adduction of the fingers and for which ulnar nerve is the one which is basically required. The electrical potential difference across the membrane based on the concentration of electrolytes is basically equated by the Nernst equation. Struma ovarii is a teratoma, you all agree with me. Now what causes the gallbladder to contract, doctor? Cholecystokinin. What causes cholecystokinin to be secreted? Distension of abdomen with food. So there is no food in starvation, no distension of gut and no cholecystokinin release and no contraction of gallbladder, hence gallbladder is distended in case of the deaths caused by the starvation is what need to be remembered. One question on sensitivity specificity. We can't get rid of this topic in the real time life until we get the seat. So sensitivity is A by A plus C, specificity is D by B plus D, and A by A plus B is positive predictive and D by C plus D is negative predictive accuracy, where ABCD stands for true positive, false negative, true negative is what you should be very sure about. Before we answer this question, tell me, doctor, left gastroepiploic artery arises from where? Very good. Whereas the right gastroepiploic artery is basically the branch of gastroduodenal artery which divides into superior pancreaticoduodenal artery and right gastroepiploic artery is what need to be remembered. Now tell me, doctor, PCO2 is 80. Do you think that it is a hypercapnic state? Definitely. When will that happen? If there is a respiratory depression, we are unable to get rid of the carbon dioxide from the body. And any respiratory arrest or depression lead to acidosis, which is a respiratory acidosis basically. So, but respiratory acidosis, unless metabolically compensated, will not have a low bicarbonate. What is the normal bicarbonate value? 25 to 30. So it is still a uncompensated respiratory acidosis because of the hypercapnia and instead of decrease of the bicarbonate, still bicarbonate is maintained 33, which is almost more than 30, the normal value, upper limit of the normal value. Now a 160 milligram drug became 80 milligram in 120 minutes. That means what is the half-life of it? 120 minutes. And what do you mean by first order kinetics versus zero order kinetics? In first order, a fraction of the drug is eliminated per unit time. In zero order, a fixed amount of substance is decreased. 100 becomes 75, 75 becomes 50, 50 becomes 25, 25 becomes 0. Every time 25 milligram for it to decrease, if it is the same time, you call it as zero order. Whereas 100 becomes 50, 50 becomes 25, 25 becomes 12.5, taking same time is called as first order. So how many half-lives are there in 6 hours, doctor? 3 half-lives are there. So that is the reason 160 become 80, 80 become 40, 40 become 20. At the end of the third half-life is what need to be remembered. Most common site for endometriosis would be ovary. You all agree with me? Chocolate cysts of ovary should be remembered. Then atypical lymphocytes which you see in infectious mononucleosis will be CD8 positive T lymphocytes which are the atypical clonal T cell proliferated cells is what need to be remembered. So what is the disease control, what is the disease eradication and elimination? The three definitions you should be very sure. Control means decrease the incidence of disease, duration of disease, effect of infection and financial burden on the community. And in control, we control, but we let it to survive at a very low level continuing in the community is all about the control. In control, at a low level where it ceases to be a public health problem, it continues to be. So that is what you will be doing in control. We say terrorism is controlled. That means terrorists continue to stay, but they don't remain anymore at that level where they are a public problem. That's the control. Then what is elimination? It is interruption of transmission is called elimination. Eradication means totally exterminating the infectious organism like smallpox is eradication. Now what are presumptive tests and what are confirmatory tests? There must be some easy way to remember this. All crystal tests for the blood detection are all confirmatory in nature. Anything else is not confirmatory. So according to Hunt, the crystal tests are regarded as the confirmatory tests, and the Teichmann's test and the Takayama reaction, they are all trying to look at the crystals which are considered to be the confirmatory test is what need to be remembered. The Bhopal gas tragedy, is it a continuous or a point source epidemic, doctor? Huh? Point source, you all agree, right? Okay. We also, I mean, there's a small correction. Now spontaneous bacterial peritonitis. There are three kinds of definition for this based on the ascitic fluid analysis. Definite SBP, probable SBP, possible SBP. You should be very sure on these definitions. Let us look into it. When the PMN count is more than 250 in conjunction with a positive bacterial culture in the ascitic fluid, if it is there, then it is called as a definitive spontaneous bacterial peritonitis. Whereas culture negative, but WBC count is more than 250, then you call it as a probable spontaneous bacterial peritonitis. Then if the positive culture results coexist, even if they are coexisting, if the PMN count is less than 250, you call monomicrobial non-neutrocytic bacterial ascites. That's how we basically define. So ascitic fluid neutrophil count greater than 250 per cubic millimeter is definitely a true definition of the spontaneous bacterial peritonitis. Then why do you call spontaneous? The difference is, suppose if duodenal ulcer is there, it got perforated, there is a peritonitis, is it called spontaneous? No. There is a definite source of peritonitis in the form of intestinal perforation. But if I have nephrotic syndrome, if my opsonins got decreased, if my immunity got decreased, and then the ascitic fluid got infected, then it is called spontaneous. So without any recognizable secondary cause like a pelvic abscess or intestinal perforation, if there is a peritonitis, then it is called as spontaneous bacterial peritonitis is what need to be remembered. Then another differentiating factor is, if it is a secondary bacterial peritonitis, you find multiple organisms growing in the ascitic fluid culture. But generally in case of the spontaneous bacterial peritonitis, only one organism will grow, not multiple. If multiple organisms are growing, it is no more spontaneous bacterial peritonitis is what you have to basically remember. Today only you should take an opportunity to revise this small, smart and a short topic, any book you read in medicine. One more topic is hepatorenal failure is one topic on which a lot of questions come. What is the case definition of hepatorenal failure, hepatorenal syndrome? You should be very, very sure.